Yeah, life.
Good evening, everybody. Welcome you all to iFocus Online. This is lecture 498, 47th episode of Refractive Surgery module. Today is a special session, a fun learning class, I must say, as today we are going to do a quiz session. We have two of our quiz masters, Dr. Kanika ma'am and Dr. Rolika ma'am. So, Dr. Kanika ma'am, she's an associate consultant with Center for Sight Eye Hospital under Cataract and Refractive Department. Welcome, ma'am. And Dr. Rolika ma'am, she's a fellow in ophthalmic plastic and reconstructive surgery at Shirley Eye Institute, UCSD, San Diego, USA. Welcome, ma'am. So, not taking much of your time, let's begin the quiz session. Over to you for the quiz masters.
Thank you, Dr. Kritika. And we welcome all of you. And Kritika, if you can, yeah, thank you. So, Dr. Kanika and I welcome all of you for the iFocus quiz on refractive surgery. And I should say that before we always start, I would mention that Dr. Kanika has put in a lot of efforts to shape this quiz, and she has made all the questions. I'm just a mediator. I'm just here to help out and provide you guys the Kahoot platform, but everything has been done by Dr. Kanika. So kudos to you. And Dr. Kanika, would you like to brief everybody about the rules going forward?
I think Dr. Rolika, you're the quiz master expert. Please go ahead. I'll help you with the explanations during the quiz questions.
Okay, sure. So,
Everyone who's attended this whole module, the refractive surgery module, I'm sure it would be easy for you. The questions are based on the classes. Dr. Rolika, you please go ahead.
yes, to support what Dr. Kanika just said is that she's put in the efforts of making sure that all the questions are taken from the previous lectures. And it's not like you don't know about it. If you've attended the module, it's kind of easy for you. So what we're going to be doing is I'm going to share my screen and you will see a game pin and a QR code. So go ahead and log in with that game pin. I'm going to start that and then I'll keep talking so that we are able to introduce you all to the quiz rules. Let me know if my screen is visible.
Yeah, the screen is visible.
Okay, lovely.
Yeah, people have started to come in.
Yeah, it takes a little while for the participants to join. So just take your time because you have to register and everything. So here is how it goes. We have 25 questions, and the 25 questions are 4 options, and only one answer is correct. And I think it's around 20 seconds that it will be displayed for. So it's best if you guys are listening to us on YouTube or Facebook, there might be a little lag. There might be like a 30-second, not even 30 seconds, like 5, 6 seconds lag between what we say and what you see on your screen. So what you guys do is that make sure that you're logged in on Zoom separately, on like YouTube or Facebook separately if you want to listen to us and see us and the explanations. And you can log on to Kahoot.it. That's the app where you, or the Kahoot app, where you can see the questions and promptly answer. That's going to be in real time. So when you see the question pops up on your screen, you click on it, it's perfectly in real time. So whatever you say, whatever you answer gets recorded over here. So this is the QR code, and it will, the moment you enter www.kahoot.it, you will see a game pin, and just put in the game pin and log in, and it's going to be that convenient. And with every question, we will also have a game board after the question. So, you will be able to assess where you stand at every level. And after which Dr. Kanika will briefly tell you about the explanation because we want this to be a learning experience as well, right? And yes, there are exciting prizes. Even the previous session that we had conducted, the prizes will reach you all soon along with certificates. So that's exciting, right? Correct, Dr. Kanika?
Yeah, the promise of
The promise of. Yes, there might be slight delay in the prizes reaching you all because we have to get approvals and everything. But it will be there with you soon. So another thing is that people ask me a lot about how to get like the higher marks in Kahoot. Well, if you answer the question quickly, you're gonna get higher marks. And if you answer the question quickly and correctly, you will get higher marks. Of course, relatively higher marks. So your aim should be to get the answer right. If at all you know that it's a tough question, you can actually pause a little bit and answer it correctly instead of just going in with like something or the other. So if you know the answer, go for it quick and fast. If you don't know the answer, wait for some time, try to make it more accurate. So that's the trick to go around it. We will just wait for some time before we start the quiz. But anything that Dr. Kanika you would like to say?
No, I think this is your area of expertise. You've
So,
been doing.
Dr. Kanika, when you were making the questions, what did you have in mind? Like, how did you cover the topics? I want, like, everybody to get that perspective. What were you thinking? Because you've put in a lot of efforts in making the questions relevant.
So the whole point behind this quiz is that it's not just a game-based activity, it's also an exercise for people who have even missed the classes to just get a gist of what apparently they are missing on. So if you have not attended any of the sessions and you feel in any of the questions that you're stuck and you don't know the answer, you go back to the module and just go through the class on the same topic. And I'm sure it has been covered in so much detail that you'll find all your answers in those classes. So the whole point was for people who have attended to just have a revision, and for those who have not attended to know what they need to read and go back and just search through the module.
That's correct. I do see a lot of familiar names and that have been the chronic quizzers. And I think that's always fun to see the similar names pop up. And we will probably wait for exact 3 more minutes before we started. Is that okay?
Yeah, I
8:10, right?
we'll wait till 8:10.
Yeah. So that because you all can still join in between at any point because the game pin is always displayed at the bottom and be comfortable. In these 10 minutes, you guys can choose where you're sitting. And if you want to Google, you can have Google around, but it's not going to help because Dr. Kanika has made sure that all the questions are not Googleable. So they are from the mental Google. So at the bottom, you will always have the game pin. If you log out, don't worry, you can always jump in. We've had people who logged out and like missed 2 or 3 questions, but then came back and you can always jump up the scoreboard. So don't worry about that. So I guess 2 more minutes and then we start off with the quiz.
Yeah, I think we have a stable population this time.
Yeah, it actually keeps fluctuating in between. Sometimes people drop out, sometimes people drop in. That's because of the connection issue. Make sure that you guys have a good Wi-Fi situation going on around you. It's very helpful because then it gives you the prompt questions. If there is any lag that you have, it will affect the scoreboard eventually.
So while we are waiting to start, I also want to thank you, Dr. Rolika, being in a different country and still agreeing to work it out and, give us your precious time and help us with this quiz. It's a really magnanimous effort on your part, and we are really grateful. Of course, we would have missed you if you were not the quiz master. It's always exciting to see you on screen.
No. I told you earlier also anything for iFocus. It's not a big deal. It's morning my side. So this is early morning for me. It's not a big deal at all. I think we have a very good quiz team, Dr. Kanika and I, right? So we both land up coordinating it pretty well. All
Correct.
right, so it's 7:40. So let's go, sorry, 8:10. So let's go ahead and proceed with the starting the quiz. So here we go. So just to brief you all with the, rules once before we go ahead. The quiz will be played on Kahoot. Please log in to www.kahoot.it and download the Kahoot app. And at the bottom, as you can see, that's the game pin visible right there. It will pop up throughout the quiz. There will be 25 questions followed by explanations by Dr. Kanika. Each questions will have 4 options. Speed and accuracy matters for the scoring, and Kanika's decision is final. Okay, so we go ahead. Question number 1 is, if the eye behaves like a camera, identify the incorrect pairs of structures over here. Option A, eyelids and shutter. B is corneal lens focusing system, pupil a diaphragm, retina light sensitive film. They are listening to me. If you don't know, they're kind of waiting and then answering.
Do we also have a background music, Dr. Rolika?
Yeah, there you go. I think I lowered it down.
Oh, I didn't expect so much confusion. We wanted an incorrect pair,
Correct.
and the wrong answer here is option number C, which is pupil. Pupil is not the diaphragm. Pupil is the aperture. It is the iris, which is like a membrane that behaves like a diaphragm. So, Dr. Rolika, we can move on to the explanation slide.
Just give me a minute. Let me connect the audio part. Just give me a second. I'll unshare my screen and reshare.
Now we can
Are you-
see
No?
no audio as of now.
Okay, it's okay. We are the audio then. Doesn't matter.
Okay,
Okay, so here's the scoreboard. So Spurti is topping it.
great.
I wonder who is Tulika. Is it like Dr. Tulika who is on it?
TNB residents. I hope I'm correct. That would make me proud.
Okay, this is lovely. Okay, so let's go to the next question. The explanation for
The
you.
explanation. So this is from one of our classes, like the first few classes of the introduction of the optics and refraction part of the class sessions for refractive surgery. Iris is actually what behaves as a diaphragm, and pupil is an aperture. Rest of the combinations are correct. The retina behaves like a light sensitive film. The eyelids are the shutters, and the cornea and lens are both working as a focusing system. So our eyes do behave like a camera.
Okay, lovely. So let's go to the second question, and that is, note the instruments in the picture. Identify the false statement related to its use. So as you can see, oh, I can hear the music now. Okay, perfect. So, traditionally used safe and effective instrument. Is it femtosecond laser is preferred alternate nowadays. Utilizes an oscillating blade to cut through the cornea. Not popular due to expensive material.
We need the false statement here. Good.
Okay.
Majority of them have got it right. Yes, the correct answer is, or rather to say, the incorrect option here is that it is not popular due to being expensive. Actually, microkeratome LASIK is very economical because the blade is a mechanical instrument that you can sterilize and reuse multiple times, unlike the femtolaser systems, which are costly and each docking interface for the patient costs a very solid amount. So they are more economical as compared to femto. Definitely, we prefer femto nowadays for the flap construction. But microkeratome have been in vogue for a long, long time, and they were also declared safe and effective until femtosecond laser was brought into the picture.
So this is our fun scoreboard, and we have a completely new scoreboard over here. Only Dr. PA has climbed up, and we have new names coming up. So do you want to briefly mention, or you have covered that?
So all the other options are entirely true. Microkeratome has an oscillating blade which precisely cuts the cornea, and the flap that is fashioned is very good actually. Before femtosecond laser, they were very popular and effective. And even today, in a lot of settings, in the periphery settings and smaller setups, microkeratome LASIK is still used and is effective. The only reason why it is not commonly performed is because of the few complications related to steeper and flatter corneas where microkeratome did not function as good as a femtosecond. So let's move to
Perfect.
the third question.
Yeah, so the third question is, in refractive surgery, MMC is commonly employed in what concentration and for what duration? So that would be 0.002% for 2 to 4 minutes, 0.02% for 12 to 120 seconds, 0.2% for 12 to 120 seconds, and 2% for 10 to 30 seconds. I still remember that I used to be the one with the clock stop for this in our ORs. So the correct answer is 0.02% for 12 to 120 seconds. And I'm happy to see that a lot of people have got the answer correct. So, I mean, maybe they are the ones holding the stopwatch too. So we have a scoreboard pretty stagnant right now. And Dr. PA is on the highest answer streak of 3. We have climbers also. So over to you, Dr. Kanika.
Yeah, so correctly, most of you have identified the right option for this. Mitomycin C, as we all know, it is used in multiple cases in ophthalmology. In refractive surgery, practically and particularly, it is used to actually reduce the fibroblastic proliferation and therefore resulting haze formation. The concentration is kept very precise and it is also calculated and calibrated according to the refractive error. Usually, it is approximately 10 seconds for each diopter of correction. So, somewhere in the range of 12 to 120 seconds, and the concentration is 0.02%. It works by inhibiting cell proliferation and specifically the myofibroblasts, very commonly used in all the excimer laser-based procedures of surface ablation. It comes in a...
Actually, another interesting, sorry, go ahead.
No, please go ahead. I know it has a lot of use in oculoplasty and oncology as well.
In fact, I remember there was a question that we used to have. I'm not sure if it still comes or not, where mitomycin C is the topic to write on. So there are multiple possibilities of using applications of mitomycin C, but the concentration differs. So you should know about all the applications where all it can be done and different concentrations of every application as well.
Yeah, and the
So
favorite question of most examiners is the color. So most of the time people get stuck because if they've not used it, they can't identify what color solution does it make. So this gentle violet or light lavender color, this is what mitomycin looks like after preparation. The granules are also in a violet hue. So you should know about this. Your practical examiners might catch you there if you've not used it and just mugged it up.
that's correct. So we go to the next question, that is, what effect does increasing the optic zone in myopic LASIK or PRK have? It increases the risk of postoperative glare and halos. It increases the chance of regression. It decreases the predictability of refractive outcome, or it increases the ablation depth. So,
It's the most
uh,
appropriate option you have to select out of these.
So I think a lot of people got confused with increasing the risk of postoperative glare and halos. So I think, don't worry, Dr. Kanika will be explaining that for you. And we have climbers in the scoreboard. So over to you, Dr. Kanika.
So the explanation to this question's answer lies in the Mannerian formula. We all know photorefractive keratectomy. It works on the Mannerian formula, which tells us the ablation depth and the direct relation of increasing your optical zone diameter is with the ablation depth. Of course, most of you have confused this with the glare and halo symptom, but the glare and halo symptoms are not only related to your optical zone, they are related to the person's pupil size in dark and light conditions. So the direct influence of optical zone is on the ablation depth. The bigger is your optical zone, the more you are ablating and the more tissue you are utilizing. That's why we keep it commonly from 6 to 6.5 millimeters. And as we increase the diameter, the ablation depth and the tissue utilization increases.
That's correct. In fact, you know what, Dr. Kanika, I was thinking that maybe next time we can actually have them for the reference lecture also. So that, I mean, I know I cut it out for making sure that it's like only the explanation, but we can actually keep where the reference lecture is and they can go back and see those reference lectures also.
We have a class on the photorefractive keratotomy basics.
Right.
Do that and
So
you
the
can
next, right, we can do that. So what is the next question is that what is the best way to prevent this post-LASIK complication? A meticulous flap realignment with minimal irrigation, use of a thin flap, use of sterile distilled water, or aggressive irrigation. Are you happy with the outcome, Dr. Kanika?
most of them are correct here. Yes. So what we see in the picture are microstriae. Now, first and foremost, you need to differentiate between micro and macrostriae. A microstriae generally happens when the flap is not very well opposed, or if the ablation is too deep and the flap architecture does not match the post-ablation stromal bed. So microstriae are generally not harmful and they do not cause a lot of symptoms, and they can be easily taken care of by proper meticulous realignment and with minimal irrigation.
Okay, so we go to the next question. That would be question number 6. That is 26-year-old with a topography and changing glass prescription wants glasses removal. This is the topography seen over here. For this topography, which statement is wrong? Not a suitable candidate for refractive procedures ever, not a suitable candidate for refractive procedures at present, maybe suitable for contact lenses or for lens-based procedures. I think this was a tricky question.
So you had to identify which statement is wrong.
Right. And the scoreboard remains stagnant. Mostly when we have difficult question, it goes the same way. So over to you.
Yeah. So like most of you have confused this. A person who has a topography like this, where we can see there is thinning, there is ectasia, especially in the inferocentral area. So we generally come to a conclusion of ectatic disorder, most likely keratoconus. Now, to say or blatantly reject them for any kind of refractive procedure is not the correct way. Nowadays, we have options to give them refractive correction. So they may not be suitable for the refractive surgery at present, but yes, in future, they can get help with a lot of other options like contact lenses, posture, C3R, and even the refractive surgery options. So these people are not suitable at present when there is progressing keratoconus, but once the keratoconus is stabilized, we can give them refractive surgery options. And in refractive surgery options, we are talking mainly about the lens-based procedures if we do not want to interfere with the corneal structure and pachymetry. So initially cross-linking, and then yes, of course, we can give them refractive surgery options based on their outcomes.
Okay, perfect. So we go to the next question, that is all are lenticule-based refractive procedures except for which ones? You can see the diagram over here. Very easy to understand with that. I think she's given a very easy question here. Smile, silk, contoura, or clear? I think the very fact that the picture is, I thought of removing the picture though, but
And sometimes in their hurry to just respond, they just forget and they get confused. So yes.
okay, so we do have a quick change in the scoreboard with Dr. Harsha and Dr. Gahan Reddy climbing up. And we have somebody who is the highest climber, Preeti. Good for you, but try to climb faster. We need to see you on the scoreboard too. So over to you, Dr. Kanika.
This was a pretty easy question. All the other names that we have put, which is smile, You can see the short forms and full forms for them. SMILE is small incision lenticule extraction. Silk is smooth incision lenticular keratomileusis. CLEAR is corneal lenticule extraction for advanced refractive correction. All of these have lenticule in their names and are lenticule-based procedures, whereas Contura is a topography-guided LASIK. And this involves creation of a flap and not a lenticule. So easy question, and most of you got it correct. Kudos to you all.
Yes, so we go to the next question, and that would be, which of the following is a benefit of PRK over LASIK? Faster visual recovery, less postoperative discomfort, suitable for all refractive errors, no risk of flap-related complications.
So if we compare PRK and LASIK, what benefit does PRK give over LASIK? Oh,
Oh,
almost
lovely.
unanimously everybody has moved one. Okay.
This is amazing. We got Dr. P on fire too. So that's interesting and a good scoreboard. So I know that you all must be thinking like, oh my God, the scoreboard has been stable now, but that you'll be surprised. See, there's a difference of nearly 1,400 points maybe between RV and Harsha. They can climb up. So even you guys have like a proper, just maybe a minimal difference, and you can climb up and change the scoreboard. So over to you.
So PRK or photorefractive keratectomy, also commonly called surface ablation procedure, involves the removal of the corneal epithelium and direct firing of the excimer laser. Because there is no flap, so the correct answer is that it gives us a benefit of avoiding all the flap related complications. So that's what it is, and rest of all the options were correct. It has a slower recovery.
Perfect. So the next question is, what mathematical model is commonly used to represent the wavefront aberrations? Fourier series, Zernike polynomials, Laplace transforms, or Taylor series? Hint, very easy question. You can just see the picture and you have the answer. If anybody gets this wrong, I will have a problem with it. Okay.
There
We
are
have
four of them.
the four people. Let me find out and catch you. It's like right there in the image. Look at the image. See again. It's written there, the answer.
See the initials written Z,
Yeah,
standing for
it's
Z
like right
polynomial.
there. Okay, so let us see how the scoreboard changes. So see now, if you notice that everybody answered really quickly, so therefore the scoreboard was very dynamic. So over to you.
Yeah. So Zernike polynomials were actually coined by Dr. Fritz Zernike, and he did not invent this for corneal structure relations. Actually, it was developed for different uses in physics and to describe the various aberrations in other dimensions. But it was then that people started to identify that corneal aberrations can also be, the wavefronts can also be represented using these mathematical polynomials. So these are used to describe wavefront aberrations, and they are categorizing them into different orders and types. These were introduced in 1953, and he also got Nobel Prize for the same.
So the next question is, in wavefront aberrometry, what does a higher root mean square value indicate? So this is the wavefront square image. So it indicates it's a better visual quality, lower optical aberrations, higher optical aberrations, or no correlation with visual quality. This is also a very easy question. So I think she gives a streak of 4 to 5 easy questions for you all. So I do understand that there is a confusion there, and I told you that you can climb up. See, Dr. Tilottama is listening to me. So therefore, you can just keep answering, keep focusing on what you are doing, and you'll be fine. Over to you.
Yeah. So root mean square value generally indicates how much of the wavefront deviates from an ideal wavefront. So the more is the RMS value, more is the deviation from the ideal, and therefore more are the aberrations. Just understand this in this way. Anything deviating from the ideal wavefront will give you a higher root mean square value. So we have a very beautiful class on wavefront aberrometry by Dr. Ritika Sachdev, and she's done a really, really great job in explaining how it goes and on the basic level. I mean, I know it is really difficult to understand, but ma'am has made it so simple. Please go back and attend ma'am's class.
Okay, perfect. So we go on to the next question. Which imaging technique is utilized by the Corvus ST to assess corneal biomechanics? So this is the setup which explains it. So I think another easy question is OCT, Scheimpflug imaging, UBM, or FA. It's very easy. I will have a problem if anybody answers it wrong. I need to meet those 4 people and these 8 people, okay?
Okay.
All right, so let's see the scoreboard. Interesting. So we have a
His
competition between AJK and Tilotima happening. Okay, Dr. Kanika, over to you.
So Corvus ST is basically a corneal biomechanical index test device, and this utilizes 2 of the parameters. It also takes into account the topography or the tomography and also the corneal hysteresis. So on the right side of the image, if you see, we can see the corneal tomography images, topography images that we are deriving from Pentacam or Scheimpflug imaging. So it is the Scheimpflug imaging that is utilized in the Corvus ST to capture the dynamic response to the air puff. So this in toto gives us the assessment of the biomechanical strength of any cornea at question.
Okay, so the next question is in a keratoconus, how does the corneal epithelial thickness typically change? So this is the diagram which kind of represents it too. Thinning over the cone apex with surrounding thickening, thickening over the cone apex with surrounding thickening, uniform thickening across the cornea and no significant change. Again, just put a logical application to it. Excellent. So it was the most expected answer. We have at least 4 people competing for the 5th position and even for the first. Don't worry, you can still. I think that there was a difference of more than 1,500 points between PA and RV, and I think Dr. RV is covering up in 900 points left. So kudos. And over to you for the explanation.
So this question is also self-explanatory and basically a learning point. Corneal epithelial mapping is also one of the ways to identify underlying ectatic changes in the stroma or the stromal thinning, because wherever there is steepening of the cornea, the epithelium shifts in such a way to balance out the remainder. And so the apex has a thinned out appearance on the epithelial mapping, whereas the just peripheral area to the apex has a thickening in order to smoothen the surface, in order to smoothen the stromal surface. So this is one way. And we all know in our corneal and ophthalmology things, anything on the warmer side is standing for steeper and anything on the cooler side stands for flatter. So epithelial mapping can also give you an idea of sometimes underlying form frustae keratoconus or keratoconus in general, which may have a good pachymetry in toto. This also identifies the borderline corneas, like sometimes on our pentacam reports, we are not sure on the tomography. So we can use epithelial mapping to differentiate between the two.
So the next question is, what is the primary mechanism by which the excimer laser reshapes the cornea? So this is the diagram showing it, and that would be photocoagulation, disruption, ablation, or thermal coagulation.
I think I may have gone too lenient on them.
I think so too. This one's very easy. Yep, that's excellent. And I think Dr. PA was like, oh my God, I need to do it faster. So she's like, she or he is like trying to get the pointers max. We do have Ju back in the game, 3 in a row. You're on fire, Ju. So here it is, the explanation.
Yes, so correctly identified by the majority. PRK or the excimer laser works on the principle of photoablation. And by ablation, we mean that when we are giving the laser energy, the photon energy is transmitted, it loosens up the bonds and the tissue is disintegrated in that particular area. Although excimer laser is a cold laser, it does not damage any surrounding structures, but the area where it is fired, it ablates the cornea. So everybody, I think, knows that.
Sure. So I'll go to the next question, that is identify the surgical procedure in the picture. So this is what has been done. A trapezoidal keratotomy or radial keratotomy, astigmatic keratotomy or hexagonal keratotomy. You think that's easy too?
Now that
Tricky.
I'm thinking, it may be.
It's a tricky, easy question.
Well, it is an easy question.
All right, so let's see what happens to the scoreboard. We do have a new name, Kriti, climbing up. So I think that this is a completely new name from the beginning, correct?
Correct.
So that's persistence. Amazing. So over to you for the explanation.
Yeah. So, although not very common these days, this indeed is hexagonal keratotomy. And as we can see, the name is so called because of the appearance. It is in the form of a hexagon and it is historic, not performed nowadays. But in the earlier days, they used to do it to correct astigmatism and also hyperopia. So, if we see the hexagon limbs, sometimes they would be connected, sometimes they would be left open. I have taken a class on astigmatic keratotomy. So the same picture is from the class, and you can go back and attend the class. Even though we are into this new generation and performing all the safer procedures nowadays, but we should know about the historical perspectives because you might land up finding such patients in your clinic. Likewise, we also find radial keratotomy patients commonly in our clinic. So yes, hexagonal also you should know.
All right, so the next question is, what is the approximate precision of tissue removal per pulse of an excimer laser? That would be 0.25 microns, 10 microns, 1 mm, or 0.1 mm.
For each pulse of excimer laser, how much tissue removal is undertaken? That's what the question entails.
Okay, interesting. We do have a stable, okay, dynamic scoreboard still. And over to you for explanation.
So the correct answer is 0.25 microns. That is 4 pulses for an entire micron. So excimer laser can remove very fine, smallest of the tissue. And likewise, the example is from Dr. R. Srinivasan, who actually used excimer laser. And he was an Indian physicist who coined the term also. And he found out that excimer laser, which was used to etch on metal chips, could also be used on the natural tissues. So the correct answer is 0.25 microns, everyone. 10 microns is not the correct answer. 10 microns is almost like 40 times.
Correct. Lesser is the better. So next question is, which of the following is a potential complication specific to excimer laser refractive surgery? Retinal detachment, corneal haze, vitreous hemorrhage, and macular edema. Disclaimer, the picture has nothing to do with it. So, so think about the answer. Or it had something to do with it.
Okay.
Okay, so we have new names. We have a name called N. I mean, we can be more creative, right? But at least we are on the scoreboard. So good. And we do have Urj having the highest streak of 10 answers. That's great. So over to you, Dr. Kanika.
So correctly identified by everyone because in a surface ablation or excimer laser ablation, we are targeting the anterior stroma where we also have the Bowman's membrane and the myofibroblasts are more active in that zone. Therefore, the haze risk is more with surface ablation or PRK procedures. It is a potential complication. That's why commonly now with our surface ablations, we use mitomycin C in order to combat the haze that may form post-operatively.
Okay, so the next question would be, which of the following best differentiates PISK from diffuse lamellar keratitis? So PISK versus DLK. Presence of an infectious agent or onset within 24 hours post-surgery, association with elevated IOP, or response to increased steroid therapy. Even this is a pretty easy logical question, I would say. If you know it, you know it. Okay, so I think I would say that people found it slightly difficult. Okay, so let's see what's the scoreboard like. Okay, so N has a streak of 11 questions. That's amazing. Okay, over to you.
Yeah. So PISK or PISK stands for pressure-induced stomal keratopathy, and DLK is diffuse lamellar keratitis. PISK, as the name suggests, is because of high intraocular pressure. Because of the high intraocular pressure and compromised endothelial pump function, sometimes the water is collected beneath the lenticule that is formed. So the anterior cap of the lenticule is separated from the stromal bed by some kind of fluid collection. And this is what differentiates it from diffuse lamellar keratitis. DLK is mostly inflammatory, whereas PISK is mostly elevated IOP induced finding. So once we reduce the IOP, the PISK tends to get better with time.
I think that's why the abbreviation of PISK was not in the question.
Yeah.
That's the reason why. Okay, so the next question is, what does a circle scan procedure entail? So that would be intrastromal pocket construction or lenticule construction, flap construction, or limbal relaxing incision creation. What it means is that during a particular scanning, the circle scan is done to represent which part. Okay, I think Dr. Kanika will need to explain that. I
Yes.
told you guys that it's pretty dynamic. We have RV climbing up, and I think that's because of persistent fast answering. And Kriti has climbed up too. This is the first time it has changed.
Yeah.
So here you
So
go.
correct answer is flap construction. And I am sure why people got confused was because of the image that I had placed. It showed two circles in the paracentral area. Probably you must have thought this is for the intrastromal pocket creation, because that was the maximum number of people who have attempted wrong. So it is not for an intrastromal pocket creation. Circle scan is specific to the Visomax laser by Zeiss, and this was introduced in order to convert the smile cap into a flap. So in cases of redo of a smile surgery, we do not go ahead and do the lenticule procedure on the second time. Instead, we convert the cap to a flap using the circle scan. And the circle scan entails firing the laser only in the mid periphery, extending from the cap end to the periphery to convert this entire thing and lift it as a flap. So again, we have a class on this, and I think I have also taken this class. Kindly go back. And circle scan is not FDA approved, therefore not performed in the USA. But yes, in countries outside the USA, this is performed.
Okay. So lovely, we have the 19th question. Which of the following best describes the primary cause of post-LASIK regression? That would be progressive corneal thinning and steepening, biomedical instability of the cornea, development of corneal ectasia due to pre-existing keratoconus, healing change leading to a partial return of the original refractive error. You have only 6 questions left to climb up. So the correct answer is healing change leading to a partial return of the original refractive error. And let's see okay, they're fighting. Okay, PA and RV are like, maybe, maybe not. Me or you. You know how the last ball always matters. So I
Correct.
think it's going to be that fun part for this quiz. So let's go with the explanation.
Yeah. So most people got confused in post-LASIK ectasia versus regression. Now it's important to know ectasia is thinning and protruding of the cornea because of inherent weakness that was not inherent, the iatrogenic weakness that was created in the corneal lamellar structure. Regression, on the other hand, does not involve thinning protrusion, ectasia. Regression is mostly because of the epithelial healing changes. So sometimes the epithelial thickens and that causes a return of power. So guys, this is the basic question. And even I, during my residency final exams, I had this question in my exam paper as an essay note. So please be very clear with your concepts. What is regression and what is ectasia? Post-LASIK regression is due to the healing responses that cause the cornea to partially revert to its preoperative shape and leading to a return of refractive error, but not a return of ectatic changes. So ectasia and regression have to be differentiated, and you should be very clear with the concepts there.
Perfect. So moving on, question number 20 is progressive myopia and astigmatism several years after LASIK, along with inferior corneal steepening, as seen in this image. What is the diagnosis? It's post-LASIK regression, post-LASIK ectasia, presbyopia, or cataract formation. So you can see the image, that's your reference image. So what do you see in the, oh, wonderful.
Really answered this question in the previous one.
That's true.
Yeah.
So you want to explain this again, or?
Be clear with this. The image showed steepening in the inferior area and post-LASIK. So definitely this was post-LASIK ectasia.
So this answer was leaked by the quiz master herself. Okay, so next question, and you have 5 to go. Which of the following is not a typical feature of post-LASIK ectasia? Stable, uncorrected visual acuity, progressive myopia and astigmatism, corneal thinning and steepening, irregular corneal topography. I have a feeling that these questions are being leaked. Correct, Dr. Kanika?
Yeah.
I think so. These are being leaked.
I'm so happy that most of them got it correct, because I thought it would be confusing to find out the incorrect option out of the all.
Okay, there you go.
So post-LASIK ectasia, of course, cannot have stable, uncorrected visual acuity. The visual acuity, the quality of vision, the glare, the halo part, and also the irregular astigmatism continues to progress in ectatic changes. Usually ectasia can happen at any time, months to years later. Regression is in the first year.
Perfect. So the next question is, which of the following is an option for presbyopia correction through refractive surgery? Presby-LASIK or the multifocal LASIK, corneal inlays, refractive lens exchange with presbyopia correcting IOLs, or all of the above? See, it's a very easy question. Those 3 people need to meet me. I think the 3 people are the ones who were going really fast and not reading all the options. I'm so sure, because the entire book entails all your procedures. So let's see what's happening here. Speed matters, accuracy matters too.
RV is on top now.
And Preeti is making a comeback with 3rd in a row. You know, you never know, Preeti, if you're the 6th one. So keep doing that. So all of the above is the answer.
So there are multiple options to correct presbyopia using refractive surgery. We can give monovision through LASIK or PRK. That is correct one eye for distance and one for near using excimer laser or LASIK platform. We can also do a presby LASIK. It is in the kind of a multifocal flap construction. We can also give them corneal inlays. And there is also an option of refractive lens exchange with presbyopia correcting intraocular lenses. So all of the above are true.
The next question is, what is the primary goal of hyperopic LASIK? Again, image shown here. Flattening the central cornea to reduce the myopia, steepen the central cornea to correct hyperopia, create a uniform corneal thickness, increase the corneal thickness centrally. Image is right there. So it's easy. Very easy. All right, so let's see what happened to the scoreboard. Pretty stable. I think everybody got it right. That's how it goes.
So correct, everyone. In myopia, we flatten the central cornea. In hyperopic LASIK, we steepen the central cornea. So no explanations for that. It's very basic.
So 2 questions more. What is true about extra procedures? Same process as conventional cross-linking. It is a therapeutic procedure after ectasia, uh, done to prevent post-op dry eye syndrome, or energy dosage is less as compared to cross-linking. Interesting. I think a lot of people are confused that whether it's a therapeutic procedure or not. So let's see what happened over here. It's interesting how RV and PA have 200 points difference. And trust me, the last question can
It's
make a lot of difference. And I would suggest at this point, just go for answering it fast. It doesn't matter whether you're right or wrong. You just answer it fast.
okay.
That's what you do in the last 5.
So, extra procedure means it is a prophylactic procedure of cross-linking that is done along with the refractive surgery in the same sitting. That's why it's called extra. Now, this is not a therapeutic procedure to correct the ectasia. It is a prophylaxis. That is, when we are subtracting the tissue during a refractive surgery, we are also strengthening the remainder of the tissue using a cross-linking. However, the cross-linking is not the same as the conventional cross-linking. The energy dosage is less. So correct answer is that the energy dosage is less. And this extra procedure can be combined with any of the refractive procedures such as LASIK, PRK, or SMILE, which reduces the further development of ectasia. It will not treat the ectasia. It is just to give a safety margin to people with borderline thin corneas.
Okay, so the last ball is here. Let's see what's going on. Last question is, where are phakic IOLs typically positioned within the eye? In place of natural lens, in front of the cornea, between the cornea and iris, or between the iris and natural lens, or behind the retina? I also went with the pace of the moment. Like, let's see whether you get it or not.
Easy ball actually for the last game changer moment.
I mean, that's why you had to be quick in answering it. Oh, let's see what's going on. So is everybody ready for the scoreboard? Do you want to explain over here, Dr. Kanika?
I think it's very basic. Implantable collimator lens can be placed in the anterior or the posterior chambers in the anterior segment. So they can be clipped onto the iris also. They can be placed between cornea and iris. And they can also be put in the lens vault behind the iris. So that is between the iris and lens.
This question also used to come, basically just intraocular lenses. That was like a very blind, long answer that used to come for all of us. So let's see what's up with the scoreboard and who are our top 5. So third position is by Dr. PA. Interesting. What happened here? Okay, so Dr. Gagan Reddy completely popped up on the second position, and we have Dr. RV on the first one. I'm sorry, Dr. Gahan Reddy. My bad. And the runners up are Kriti and Harsha. I must appreciate Dr. PA. You were on a complete streak from the beginning, and then Dr. Gahan completely swiped up in the last moment. So, congratulations, everyone. Can you all do me a favor? Please send in your information to Dr. Kanika. Dr. Kanika, would you want to tell your details, please?
Yeah, so I'll just put it up on the chat box here.
Actually, chat box won't help. Wait, can you write it on a Word document quickly and share your screen? That will help.
Just give me a minute.
So the 5 of you, please send your information in details to Dr. Kanika Bhardwaj, and I would say please send your entire full name. I mean, we would love to address your full name over here on the final panel, and I think Dr. Gahan Reddy agrees that his name was addressed on the final panel. And send your phone number, your address, and your emailing address. It will help. If you have written, please let me know, then I will unshare my screen. And congratulations. I really think that was a complete last moment change. I can already hear and sense the celebrations that are going on around Dr. RV and Dr. Gahan and Dr. PA. Very good job done.
Yes.
Best part I feel was like in the first, I think first 15 questions or so. Dr. PA was on a streak, and then Dr. RV was like, maybe I can keep
The
fighting.
final questions, final 10 questions were actually the easy ones. I don't know what happened.
Yeah.
Probably he got busy with dinner.
Or it's about like, sometimes being calculative about getting the right answer. And then it's about accuracy and being fast. Okay. So are you ready to share your screen? So over to you. You can share your screen and that will be the information that you all have to reach out to.
Address, and you have to send your phone number, full name, affiliation, and your email address.
So that's wonderful. Thank you, Dr. Kanika, for all the amazing questions and for keeping everything together. Thank you, Dr. Kritika and Dr. Garvita, for being there and supporting and making sure that everything is in place. So, thank you, everyone. And thank you, Sunil ji, for being there for us always and on time. So, and thanks to all the lovely participants who came and who enjoyed the quiz. I hope this helps. The intention that Dr. Kanika and I had was to have the previous classes recapped because if everybody has put in all the efforts of going through the lectures, it's only fair to address those questions in the quiz. And we were impressed to see that a lot of people got the answers right, which means that we are happy that iFocus lectures are helping you all. So, anytime, anything else, we are always available. And over to you, Dr. Kanika, if you would want to say something.
I would also like to thank Dr. Garvita and Dr. Kritika. They're part of our team, and Dr. Garvita has also helped me with the quiz. So, background worker here, but definitely without her help, it would not have been possible. And thank you, Dr. Rolika. I would like to thank you immensely for taking out time, being in a different country on a different time zone. We do really owe to you. And congratulations to everyone, all those who have won, and all those who have made very good effort, even the runner ups. We are really happy to see that you're learning and it is helping you all. Please go through the iFocus online module if in case there is any question or if there is any doubt also, you can mail me on my mail address as well. We can connect you with the experts and get your doubts cleared. So I think we can call it a night. And for you, Dr. Rolika, all the best for
Good
you
morning.
the morning.
All
Let's
right.
a night today. Good night.
Good night, everyone. Take care. See you.
Good night, ma'am. Good night, ma'am.